because you guys requested it. So keep letting us know the topics that you all want to see. And we will go ahead and make sure we work those into our calendar. We do take that into account. After all, we're here to help you. So let us know how we can best do that. So you know this live will be on demand on all of our social channels. If you want to use it for your future reference, if you're covering neuro in maybe some of your nursing school curriculum, or if you are studying it, of course, for your NCLEX, drop back in on any of our social channels. I find the YouTube channel easiest to reference because you can just search for whatever topic you're looking for. But so you know, you are able to use that as a reference. And as always, drop your comments, your questions, and your answers to today's questions into our chat feature. We have content experts, Nurse Jackie, standing by monitoring, and she is ready to go. She wants to hear from you. I'll go ahead and pull my chat up now. And let's get it started off by letting us know, where is everyone joining from? Who here is joining us from the good old US of A? Who is an international viewer? Let us know. Let's get that chat started. And with that being said, let's go ahead and get started on all things traumatic brain injury, or TBI. So the patho here, let's look at the overarching patho behind TBI. TBI can be open or it can be closed, meaning it can occur with or without a break to the skull. Open would be also referred to as like a penetrating brain injury. So TBIs can result in either temporary or permanent brain damage. A temporary brain damage would typically result in like an altered level of consciousness. However, this would resolve itself, i.e. temporary, and the client would eventually be able to return to a normal level of consciousness. Now, on the flip side, permanent brain damage, unfortunately, is going to result in impairments such as cognitive, physical, as well as psychosocial impairments here. So we're going to switch to our types of brain injury table, and there are a couple different classifications of brain injury. So let's go over a few of them. We'll start out with concussions. So these are mild TBIs. They usually result from a mild blow or a bump to a head, a bruise of the brain. So we call it a focal injury because it is localized, and symptoms here are really going to vary depending on the location in the brain. So it could affect a speech center, it could affect some kind of thing that deals with spatial ability or spatial paralysis. We can also, next moving on, would be diffuse axonal injury or cerebral edema. So a common cause of this is going to be high-speed motor vehicle collision. That's a really common cause. And what it does is it causes the shearing of the brain's hemispheres. So as the brain and skull are whipped back and forth in that high-speed vehicle collision, for instance, it's those crashing and those braking forces that cause the shearing of the white matter tracts. These are what connect the right and the left side of the brains together. So it leads to diffuse brain swelling, which can result in a really severe DAI, which eventually can lead to coma. So unfortunately with this injury, it's a very high mortality injury, and if the client does survive, they can often be left in a vegetative or coma-like state. Alrighty, I see lots more chats coming in. I see that there's an echo, so we are working on that. Alrighty, we'll see. Alrighty, thank you for letting us know. We are on it. We always appreciate y'all letting us know. We're gonna move on to skull fracture. So this can come in a couple of different forms. We have a linear skull fracture, which occurs across a suture line of the skull. We can see a depressed fracture, which means that a piece of that skull is being pushed downwards into the brain, and it can also damage that underlying brain tissue. We can see a comminuted, which would be bone that's shattered into smaller pieces. And all three of these fractures, like I mentioned before, can lead to damage to that underlying brain tissue. Alrighty, next we'll move on to hematoma, which is going to be, I'm sure you guys can guess, bleeding in the brain. We can see epidural or subdural or intracerebral hematomas. Intracerebral would be bleeding from deep within the brain tissue. We're going to cover this in more depth later on. We have a great graphic for you all to use, so we'll just bookmark that one for now. Alrighty, moving on to clinical features. So clinical features here are going to be pretty broad. Symptoms of TBI are going to be due to the brain swelling that results and contributes to an increased ICP or increased intracranial pressure. So these symptoms will include things like nausea, vomiting. A hallmark sign of increased ICP is going to be projectile vomiting, and I can promise you, once you see that for the first time, you will never forget it. Worsening headache, we can see increased drowsiness like difficulty arousing. These clients may have confusion. We can see behavioral changes such as anger and irritability, and motor problems can result. Things like slurred speech, weakness in extremities. We can also see sensory disturbances, things that affect things like our numbness. Vision changes. We can have blurry vision, photosensitivity or the sensitivity to light. And we can also see pupillary changes. The pupils are going to be a really great guide in all of our neuro assessments. So we can see pupillary dilation or constriction, and we can see it bilaterally or unilaterally. So a lot of changes that can take place here. Increased intracranial pressure can also lead to seizure activity, which is important to note. And our overall gold standard for diagnosing any head injury is going to be that CT scan. We confirm with the CT scan. Alrighty, so let's move on to our skull fracture slide. So I want to make sure we cover this one in full because there are some really unique clinical features that are unique to clients who suffer these basilar skull fractures. Things like battle sign, which is going to be the bruising behind the ear and that mastoid portion right behind that lower ear. We can see raccoon eyes, which is exactly what it sounds like. That's bruising around the eyes or black eyes, so to speak. And we can also see leaking of CSF or cerebrospinal fluid. It can leak from the nose or the ears. The nose would be a CSF rhinorrhea and the ears would be a CSF otorrhea. It's typically clear fluid, but if we have this skull fracture, usually that indicates some kind of trauma, so it can be red tinged due to the blood from the trauma. And the key sign is that it leaves a halo sign, so that little ring around it of that clear fluid, the halo sign is going to be a key indicator that it is cerebrospinal fluid or CSF. So I'm going to ask a question to the chat. When a client has a skull fracture or a suspected skull fracture, what kind of tube would we avoid using? What would we not want to intubate the client with? What tube would we not use in a client with a confirmed skull fracture or a suspected skull fracture? I'll give you a few seconds to drop your answers in the chat. Alrighty, a few more seconds. I see some answers starting to come in. Alrighty, and you guys got it. It was an NG tube or a nasogastric tube. So with basal skull fracture, we have severe trauma to those facial bones, and the bones that connect the base of the brain, whereas the front of the face, are really closely connected. So if this bone integrity is compromised or fractured and we feed an NG tube up there, we can accidentally go through that compromised bone and intubate the brain, which is not what we want to do. We want that NG tube to go through the nose and down the esophagus, not into our brain. That's really dangerous. So we don't use an NG tube in clients with confirmed or suspected skull fractures or really any major facial trauma. Alrighty, so moving on to our epidural and our subdural hematoma slide. As promised, we're going to cover this in a little bit more depth. So epidural hematoma is going to be blood that accumulates between the dura mater and the skull. So the cause of this is going to be arterial bleeding. Our arteries are a little bit bigger than our veins are, our vessels are. So because of this bleeding coming from the artery, these neurological symptoms are going to come on very quickly. It's a very acute, rapid onset. So this causes rapid hematoma expansion. That blood keeps on coming from those arteries, which will result in quickly increased ICP or just increased ICP. And it contributes to the quick neurological decompensation of the patient. So some signs and symptoms of an epidural hematoma are going to be that quick onset or acute change in level of consciousness. We're going to see headache, usually a severe headache. They can have nausea and vomiting. And again, like I mentioned before, increased ICP can lead to that projectile vomiting. It's important to note that epidural hematoma is an emergency. We need to act fast. We need to quickly notify our providers, and they typically require surgical evacuation. So time is key here. We really have to act fast. Now moving on to subdural hematoma, this is a little bit different. So blood here accumulates between the skull and the brain, so it's underneath that dura mater. It's a little bit deeper. It's caused by venous tearing and bleeding. Again, it's a vein here rather than an artery as an epidural. The expanding hematoma does lead to increased ICP, which eventually can compress the brain, which is really dangerous. It can be acute if there are a lot of vessels involved. However, we can also see this be a subacute or even a chronic problem if only a few vessels are affected and that bleeding is really, really slow. So nursing interventions here, something really important to bring up is that Glasgow Coma Scale, or the GCS. You may hear this referred to as like a GCS score. This is used to determine symptom severity by using things like verbal and motor responses, as well as eye-opening abilities. It's like a key tool in our tool belt for a neuro client. So the lower the number on a scale of 1 to 15, the worse off this client is going to be. So 8 or below is indicative of a coma-like state. A mild TBI is going to rank at like 13 to 15. A moderate TBI is going to be more like a 9 to a 12. And a severe TBI, again, traumatic brain injury, is going to be less than or equal to 8, which essentially means there's not a lot going on here, not a lot of function. This client most likely needs intubation to help with their respiratory drive. This is a very, very serious injury. Alrighty, so other nursing interventions here, we're always going to assume neck injury until we've ruled it out, and we want to stabilize that cervical spine. Clients will be placed in a hard collar to keep that cervical spine stabilized. We're going to always be monitoring for increased ICP, and we can use some of the signs and symptoms we just went over to monitor for that. Oxygen administration may be required for these clients. We're going to want to make sure we maintain IV access. So ideally, we'll have access via 2 large bore IVs, and clients with neuro injuries typically receive 0.9% sodium chloride. We also want to make sure we work to maintain normothermia. So we have brain injuries that can control some of those centers that control homeostasis, that control our temperature regulation. So we want to make sure these clients are in a normal range for temperature, that we have a blanket on them. Maybe it's a warming blanket. Maybe we need to use warmed IV fluids to keep their temperature up high enough. Again, like I mentioned before, clients with a GCS score at or below 8 will most likely need intubation. So they're going to need mechanical ventilation, as the respiratory drive may also be depressed because we have that lack of function in these coma-like clients. Pupillary assessment, another really important tool in our tool belt for a neuro client. We want to check size of the pupils, reactivity, like reactivity to light, and we want to assess, is it a unilateral or a bilateral change, and is it progressing over time? Is it getting worse? Is it getting better? We want to always check for rhinorrhea and otorrhea, so ear and nose drainage, because we're looking for signs of CSF or cerebrospinal fluid leaking. It's typically a clear fluid. However, if there's trauma, it can be red tinged due to that underlying blood or bleeding. And another thing here that's similar to this point is we want to make sure we check for any scalp wounds or open skull wounds. If this client has a head injury, a traumatic brain injury, we want to make sure that there's no opening in the skull that caused this, which of course is an infection risk, and we want to make sure we control the bleeding here. Alrighty, I see that Carlita passed her exam. Congratulations, way to go. Moving on, we talked a little bit about CT scans, but these are going to be done serially to check the client's status when they, of course, first get admitted, and also to monitor how they're doing. Is their condition improving? Is it getting worse? This is how we're going to check in on that. Depending on the result of the client, if they may require surgery. So we can also see the implantation of something called an intraventricular catheter, or an IVC. And what this does is it may be placed to monitor ICP continuously, so we know what the intracranial pressure is in real time. And this can be used to monitor it to prevent any further damage, kind of like the same idea as an arterial line, but instead for the brain instead of the heart. Alrighty, positioning. Now this is so important. We want to maintain the head of the bed elevated at about 15 to 30 degrees, so a pretty minor grade here. And the exception to this would be with spinal injury, where we want to make sure this client is flat. The head should remain midline. We want to avoid any neck flexion, neck extension. Keeping it midline helps us to minimize the ICP, whereas turning it head and neck extension and flexion can actually increase our intracranial pressure. Alrighty, moving on to medication, such an important part to always hit on our pharmacological topic. So medications here mostly revolve around controlling that ICP, or that intracranial pressure. I'm going to ask another question out to the chat. What is a common diuretic medication used in a neuro setting to decrease that ICP? So it's often used in like a neuro ICU, any kind of neurological setting, and it's an osmotic diuretic. I'll give you a little hint there, and it helps us to decrease that intracranial pressure. I'll give you a few seconds to answer. And I see someone is coming from Germany. Welcome. Alrighty, and you guys got it spot on per usual. Mannitol was the answer I was looking for. This is a very common osmotic diuretic. It's used in many neuro settings, typically given IV. What it does is it pulls fluid off the brain from the brain into systemic circulation so it can go to the kidneys and get diuresed and get it off the body, and most importantly, out of the brain. So important to note, one thing about mannitol is it does have the potential to crystallize, especially at lower temperatures. So we always want to make sure our IV mannitol is being kept at the correct temperature per our pharmacists. And we want to make sure we look and check and see if it's crystallized before we administer it. This should be given through a filter needle, all important nursing interventions to keep in mind. Alrighty, so monitor and prevent complications. We want to make sure that we monitor for seizures. This is a really common complication of increased ICP. Brain injury as well as ICP are what lead to seizure activity, so making sure we're enacting our seizure precautions. Fever and infection are also important things to note for. If it's an open fracture, that's a big risk for infection. Also, fever and infection both increase the body's metabolic rate, which can in turn increase our ICP. Remember that TBI and neuro settings, what we're really trying to do here before everything else is control and monitor that ICP. Anything that has the potential to raise it is something we're going to want to closely monitor. Most of these clients, especially if their GCS scores are less than 8 or 8 or less, are going to be sedentary. If they're in a coma-like state, they're not moving much. And if they're just suffering a TBI, they're most likely also not going to be moving much. They're going to be sedentary, so it's important to make sure we have our DVT prophylaxis, whether that is something mechanical like SCDs or something chemical like a heparin or a Lovenox. And also important to note is that stress ulcers can develop from a TBI. Alrighty, so moving on to our craniectomy image. All right, this looks pretty gnarly at first glance, but let's talk a little bit more about this. So craniectomy is when a neurosurgeon removes a piece of the skull in an effort to decrease the client's ICP. The surgeon will then take this piece of bone off the skull and then close the skin and the muscle layer back up without ever reinstalling that piece of bone. And what this does is it allows the brain room to expand. It helps to decrease the ICP. However, it does leave the client very vulnerable to injury. Without that protective piece of bone, there's nothing that's protecting that brain. So we want to make sure we're always positioning the clients either on their back or on their non-operative side. We will never position them on that operative side because, again, there's nothing protecting that brain. It's just a skin and muscle layer. There's no hard bone to protect. We also want to make sure we're monitoring any drain output, looking for signs of infection, looking for increased bleeding that could signify hemorrhage. We want to make sure we monitor head dressings frequently, keeping a close eye out for the same things. Alrighty, y'all did so well. I see someone saying TPI, meaning it's TBI, traumatic brain injury. That is what we were covering today. Sorry if you thought I was saying TPI. Alrighty, so we're going to move on to question number 1 today. So question 1 is an intervene question. The nurse here is observing a staff member caring for a client who sustained a traumatic brain injury without cervical spine injury. The nurse should intervene if the staff member is observed. Option 1, turning the client using the log roll technique to remove soiled linen. Option 2, checking the client's pupils for size in reaction to light. Option 3, monitoring the client's gag and cough reflexes. Or 4, placing the client in Trendelenburg position. Go ahead and let us know. And just so you guys know, if you haven't checked out uworldnursing.com, there is no time like the present. It gives you a full calendar of the next 3 weeks of all the topics we plan to present, what times we're going to go live, and what channels we're going to go live. Now we also have an additional feature. If you scroll to the bottom of uworldnursing.com, we have a question of the week link. I know you've probably seen our question of the days that we put out on our social media, but now we're also putting out a question of the week. You can go here, you can sign up, and you can get an email straight to your inbox every week that gives you a question of the week as well as a full rationale. Again, this is a really great resource, but most importantly, it's a really great free resource. So if you're still trying to figure out how you're going to study for your NCLEX, what your game plan is, all of these free resources are great ways to get acquainted with UWorld, see all that we have to offer before you purchase. So again, uworldnursing.com. It's our home base for all of our nursing social efforts, and the link at the bottom will take you to question of the week. I think it's just labeled question of the week, so pretty simple. Alrighty, and Gwendolyn says, I can't keep calm. I passed my NCLEX exam. Congratulations, way to go, Gwendolyn, that is so exciting. Alrighty, I see lots of answers coming in, and good news today. Our first live of February, you all got the first question correct. Option 4 was indeed our correct option. So Trendelenburg position, remember this is an intervene question. So we're looking for our incorrect action or our incorrect intervention. So Trendelenburg is when we have the foot of the bed elevated, so the feet are high, but the head is down. So foot of the bed elevated, head of the bed down. We want to avoid this with our neuro clients. We're having them elevated head of the bed at 15 to 30 degrees. So our head of the bed is going to be higher than our foot of the bed. We're not going to be placing these clients in a Trendelenburg position. Other things to remember here is we want to avoid flexion or extension of the neck. So keeping the head in a midline and neutral position. We can also cause hypotension if we're up too high on the flip side. So we say about 15 to 30 degrees elevation of the head of the bed, and we don't put them too upright because this can cause hypotension. If you're ever adjusting the bed for whatever reason, we also want to make sure we do this very slowly to prevent worsening the injury. Alrighty, so options 1, 2, and 3 were incorrect. Why was this? So option 1, these, again, they're correct actions, therefore we don't need to intervene. So we want to make sure that we log roll the client as option 1 says, because we want to make sure we're keeping that head midline. We're not just rolling the body and keeping the head in place. This keeps all of our spine and our head in one line. So log roll is a perfect technique to use for a neuro client. Option 2, checking the client's pupils and size and reactivity to lights. Again, in our neuro tool belt, those pupils are a really great indicator of brain health. So this is going to be something that we commonly use in a neuro setting. It's a good overall indicator of brain health and if injury is staying the same or if it's worsening. Option 3, monitoring the client's gag and cough reflexes. This is a great way to prevent aspiration, see if they're losing any more of their reflexes or if they're just staying the same baseline. So again, we want to do this to prevent aspiration. Options 1, 2, and 3 were our incorrect options, and option 4 was our correct option. Way to go, you guys. Alrighty, question number 2. So the nurses attended a staff education program about seizure precautions. Which of the following statements by the nurse would indicate a correct understanding of the program? Select all that apply. So option 1, I should ensure there is suction equipment in the client's room. Option 2, I will document the duration and the behavior observed during a client seizure. Option 3, I should raise the head of the client's bed during a seizure to protect the client's airway. Option 4, I will activate the call light to request assistance if a client is experiencing a seizure. And option 5, I should insert a tongue depressor in the client's mouth during a seizure to prevent injury to the tongue. Alrighty. I'll give you guys a few seconds. Again, it's a select all that apply. It's a statement question, so a little bit longer. Make sure you take the time to read all the questions thoroughly. And so you know, UWorld is partnered with NSNA, the National Student Nurses Association. We're really excited about this partnership. We're going to be doing a couple of different webinar series throughout the year. I believe there's 6, as well as having a really big presence at the April convention, which will be in Seattle, Washington, and then the fall one, which will be in Columbus, Ohio. So we're really excited about this partnership. If you're not a member of the NSNA, I would really recommend that you do it. I believe the dues are $27 a month. But we have a lot of really great resources that will be available through this. We're putting on an extensive NCLEX review throughout these webinars, as well as especially at these conferences, which you're actually able to buy virtual tickets to. So make sure you check that out. It's a really great resource. If you're not familiar with the NSNA, they're on all socials. Check out their website. Again, another really great association for student nurses. And so you know our schedule for the week. On Wednesday, we're going to be doing a select all that apply question drill with Nurse Jackie at 2 and 3 p.m. Central Standard Time. And we'll be back on Thursday with a hematology question drill. I'll be going live at 11 a.m. and the fabulous Nurse Nicole will be back at 3 p.m. Central Time, again with hematology questions. Alrighty. So I'm going to go ahead and check our chat, see what everyone is thinking. And I see a couple of 3s mixed in, but mostly I see 1s, 2s, and 4s, which indeed was our correct options. Way to go, you guys. All right, so what we're really asking here is, this is just a question essentially about seizure precaution, and it's positively worded because we're looking for a correct understanding, i.e. correct statements. So in option 1, I should ensure there is suction equipment in the room. So important. Seizure precautions include making sure we have suction equipment at the bedside at the ready if a client were to seize. Other important things is we want to make sure we pad the side rails, the head of the bed. We also want to make sure we're removing any restrictive clothing that the client could injure themselves with if they were to seize, and any objects that could harm them, anything sharp, needs to be removed from the bed, from their immediate vicinity in case they were to seize. And we want to make sure they don't hurt or cut themselves with this. And the priority during a seizure is to always stay with the client. We want to do the things as described in option 2, stay with the client, monitor the duration, the behavior, and make sure we're tracking and, most importantly, charting that as well. We also want to stay with them through the post-ictal phase. And option 4, we want to call in some buddies, activate that call light to request assistance, making sure we're getting some friends and some support in the room. So 1, 2, and 4 were correct. Option 3 and 5 were incorrect. So why was this? I should raise the head of the bed during the client's seizure to protect the airway. We're actually going flat. Option 5, I should insert a tongue depressor in the client's mouth. First and foremost, during a seizure, nothing goes into the mouth. There's a huge risk for injury here. We're not inserting anything into the client's mouth during a seizure, not even suction. We're going to save that for the post-ictal phase in case they're aspirating saliva, maybe blood, but we're not putting anything into the client's mouth during a seizure. Y'all did really, really well. Way to go, you guys. Alrighty, great job. So we're going to move on to a QBank slide. This is a great reference for anyone that has already purchased UWorld. Here is how to go to our QBank and get more neuro questions. We did a lot of learning today. Traumatic brain injury is a really complex topic, so if you want some more questions on this, you want a little bit more practice, here is how to navigate via subjects and systems to more neurological questions. Go ahead and test your knowledge with maybe a practice test after today's questions. And in closing, thank you so much for staying tuned. I hope that you found this helpful. Neurological complex can be pretty complex, so mastering today's content as well as neuro content altogether requires some dedicated study time, but you guys did so great today. I know you're off to a great start, so way to go. Again, all of these lives will be on demand on our social channels. I think YouTube is the easiest to search, so go ahead and check that out if you want to revisit it in the future. And another reminder, join us at 2 and 3 p.m. Central Standard Time for Select All That Apply questions with Nurse Jackie tomorrow. Thank you guys so much for joining, and I hope to see you next time.